method. So what are your triggers for starting the mechanical ventilation? That, obviously we're trying to keep patients off the vent as best we can, but there's obviously a tremendous number of folks who ultimately we do have to intubate and put on mechanical ventilation. So what kinds of triggers would you want the non-ICU clinician to know about before going down that pathway? What leads you to start? When do you decide to intubate someone?
So again, I think that very much has to do with your experience pre-COVID, and then I think your COVID experience is invaluable in making that decision, knowing what you can get away with. It's a little bit off kilter for a second, but we sent people home as other places did with very low SATs, 80s. Back in the beginning, maybe a little later, we didn't do that, and we were more able to admit people. As far as deterioration, so one of the things that's out there, and it's just something that can be utilized just as another tool, and there's been debate about it, is the ROX index. And so this looks at 2 hours, 6 hours, and 12 hours, and basically considers the saturation, the FiO2, or the amount of oxygen you're giving, the patient's respiratory rate, and their COVID status, but let's assume all these folks are COVID proven, and especially when someone has flu-like symptoms. And Ryan, you could certainly talk to that. In COVID, we assume it's COVID until proven otherwise.
Exactly.
Yeah, and testing is all over the place. Here in Miami, we're lucky and we have lots of rapid testing capacity. In other places with my friends across the country and beyond, people may take 36 hours to get a test. So, but at the end of the day, we just assume they are. I think it has some utility. We tried it for a while. It's just another piece of the puzzle, just like, say, a procalcitonin, looking at a patient who we're kind of trying to figure out, are they, truly infected or are they not? And, putting together all the things we would. So I think that that's something that's helpful. And then obviously, if, as Maureen, had mentioned earlier, if we were on, face mask or non-rebreather, which maybe delivers 70% at 15 liters, and we go to high flow because we want the flow, which, helps mitigate some of the air hunger that occurs with the hypoxemia. Because if you think about a ventilator, the average setting on a ventilator for flow is about 50 liters per minute. Many of us use 60 liters for reasons that are beyond the topic of the conversation, to look at airway graphics. But, essentially, if they're failing and they're getting extremely tachypnic and they're, beyond what you'd expect, and obviously these folks have a lot of tachypnea, but you just feel like they're going to arrest soon, then that is probably the point where we're going to intervene. But certainly if they're pregnant and they have decreased functional reserve or FRC, if they're obese for the same reason and they have, decreased ability to, maintain, or they're very high risk for an intubation, then I think that would push us towards, potentially doing this earlier from that perspective. I would note with these hypoxic people, and we will get into this, I guess, we would have given them Decadron at this point, or some steroid in that equivalent. It's probably a little bit down the road, the question for that, but as I'm thinking about it, and maybe something to control their respirations, such as dexmedetomidine, depending on the environment. Positioning, of course, as Carrie mentioned, I think is key. We want to maximize that before we intubate. So I think it's the same thing. We want to maximize everything we could do to avoid it at all costs, but when it's needed, it's needed. And there's a lot of things that go into making that decision. It's not simple, unfortunately.
No, absolutely. And I would say, just for me, looking at when I'm at the bedside deciding if I'm going to intubate somebody, in addition to vital signs, really level of consciousness, I find, is one of the big triggers. When I find someone who's satting, 89, 90% on high flow, but they're also sitting upright in their bed, looking at their phone, waving at me, I'm generally not terribly worried about that person, although we'll continue to watch them closely. Whereas the person who is delirious, no longer able to interact or follow commands easily, that level of consciousness as a trigger for needing advanced airway support is one that I put a lot of stock into.
That's a great point.
Yeah.
I agree with that wholeheartedly. And one of the other pieces, and this may be my theme for this conversation this evening, is to really trust your judgment and your clinical expertise. COVID is unique and it's been very frightening to all of us, but it doesn't mean that some of the actions that we would take to manage an individual patient are any different than what you would do with some other disease or disorder. So, that level of consciousness, the change of that, my population of patients, when they said, I'm too tired to breathe, that's a key trigger for us to recognize whether or not they now need invasive mechanical ventilation versus pushing the non-invasive modalities farther. So trust your judgment.